welcome our first presenters, Dr. Michael Koeckert, Kathryn Hobbs, and Jennifer Pazderny, presenting Empowering Choices, the Art of Shared Decision Making.
Good morning. Good morning, everybody. My name is Kathryn Hobbs. I'm the former cardiac surgery nurse navigator for Houston Methodist The Woodlands. I'm joined today by Dr. Michael Koeckert, a cardiothoracic surgeon for Houston Methodist The Woodlands, Jennifer Pazderny, the CV nurse navigator for Houston Methodist Sugar Land, and Elizabeth Golden, the new CV surgery coordinator for Houston Methodist The Woodlands. Today we're going to be talking about shared decision making. By the end of this lecture, you'll be able to understand what shared decision-making is, the tools that can be used to help facilitate it, the different cardiac procedures that are used for this, and the multidisciplinary heart team approach. So what is shared decision-making? Shared decision-making is a model that helps patients make informed decisions about their health care by incorporating their values, preferences, and the best evidence-based practice. This is also a recommendation by the American College of Cardiology and American Heart Association for the management of cardiovascular disease and structural heart disease. There's essentially 5 steps to shared decision-making. The first is to get the participation of the patient and their family and explore the options that are available to them. In addition to this, you want to incorporate their values and preferences to reach a decision that you all agree on. There are some tools that can be used to aid in this. The ACC Cardiosmart, which is used by some of our TAVR programs. The NICE tool, which is used by some of our Watchman programs. SPARC Tool, and the Ottawa Personal Guide. I'm going to go ahead and hand it over to Jennifer to talk more about the heart team approach.
Good morning. So the shared decision-making is the cornerstone for the multidisciplinary heart team. So most hospitals now have a heart team that definitely reviews all of our TAVI versus SAVR cases, and then sometimes we even do the bypass patients versus PCI. So the heart team helps keep all the care centered around the patient. And we're going to look through the whole aspect of the surgery process, all the different phases. So pre-op, we're looking at the social detriments of CV health, the risk and benefits. We're looking at the frailty test, the Syntax score, the acuity of the patient. And then pre-procedural aspects, we're looking also to see if there's going to be any pain management, do they have any sedation concerns, anesthesia concerns, or any antithrombotic therapy. And then post-op, we can do a wonderful surgery, but we've got to make sure we can recover them appropriately. So we're also looking at cardiac rehab, smoking cessation. What is their psychosocial interventions? Do they have a safe place to discharge to? And then being able to manage their CV risk factors. So who are the members of the heart team? So the members of the heart team are your cardiac surgeon, your interventionalist, cardiologist, and your primary cardiologist, CV anesthesia, your echo specialist, your coordinators. Usually we have someone from the ICU designee on it, and then your CV nurse practitioners or PAs, hospital administration, and then usually your surgical database managers. So the process of setting up a multidisciplinary heart team meeting. So this took us a little, I'm from Sugar Land, so we actually review all cases before they go for open heart surgery. So to do it, first of all, we had to figure out a meeting time that worked for everybody. So we actually meet on Fridays at 7 a.m., and I know some places do it in the afternoon. So first of all, we set up our meetings. Then next, the cardiologist or the surgeon will submit their cases, and then we'll collect all the data to review, the H&P, your echoes, your PFTs, the frailty assessment. So we prepare a packet with all of that. And then if there's any external images, we make sure we upload them into the system. And then once we have the meeting, we're going to discuss all forms of therapy. We actually look at all the films and review the patient's preferences through all of it. The cardiologist or the surgeon will present their case to the heart team. If it's a TAVI, we'll also look at different access sites. We'll utilize shared decision-making to provide a consensus management of the decision. And then we'll document the recommendations in the chart, and then the physicians will discuss the recommendations with the patient. This is just an example of our documentation. We use like a SMART phrase or a template to say who was there and what our decisions were. So now Dr. Koeckert will go more into the guidelines.
Great. Good morning. So just wanted to go through a few examples of how we implement this multidisciplinary shared decision-making in practice. We're going to talk about a couple of the most common valvular heart issues that we deal with, and as well as coronary disease. So, this multidisciplinary team is not just a buzzword, it's actually in the guidelines themselves as a Class 1 recommendation from the ACC AHA. So first we're going to talk about aortic valve disease, particularly aortic stenosis. The reason we're going to spend the most amount of time on this is you have two pathways to go down, either surgical or transcatheter. So when you're first assessing a patient with severe aortic stenosis, the main question is, are they symptomatic or not? So symptomatic patients with severe aortic stenosis need either surgery or a TAVI. In the asymptomatic population, it's a little bit more nuanced, but the takeaway is if their left ventricular function has been affected, or if they're undergoing cardiac surgery for another reason, you should also be replacing their valve. So why is the onset of symptoms so important, and why do symptomatic patients require treatment? It's not just for symptomatic relief, but it's also for survival benefits. So this is kind of a classic chart graph of survival in patients with aortic stenosis. So as soon as you have the onset of symptoms, your mortality goes way up. And the graph is showing, I don't have a pointer, but without replacement, your 50% mortality in 2 years is the number we usually quote. But once you replace the valve, which either SAVR or TAVR, you get right back on that survival curve. So busy slide, you probably can't read it, but we're going to break it down a little bit. So this is the kind of treatment algorithm, and this is, the kind of discussion that we have during our multidisciplinary valve conference when we're assessing patients with severe aortic stenosis who require valve replacement. So it starts with the risk assessment. So if they're high or prohibitive surgical risk, they're obviously going to go down a transcatheter pathway, or in some cases, a palliative care. So transcatheter valves are really only appropriate for patients who are going to have some reasonable quality of life for at least a year. So patients with severe dementia, end stage, like stage 4 cancer rather, would not necessarily be a TAVR candidate. So assuming that they're an appropriate risk for surgery, then the next part of the pathway is important to take a minute to touch upon, and it's whether or not they are a candidate for Coumadin. So the reason this is important is you have to decide between mechanical or a bioprosthetic valve. And this is worth spending a few minutes talking about the nuances here. So first, you need to know if there's a contraindication to Coumadin, so a patient who has a history of multiple GI bleeds, things like that, or if they're not a compliant patient, so if they're not going to reliably take their Coumadin, or in certain situations, a young woman who wants to carry a pregnancy to term may not want a mechanical valve because of the risk to the baby. So all those things go into this decision tree. And then, of course, age. So The reason age is so important, this kind of confusing chart on the bottom, is basically showing that these bioprosthetic valves have a shelf life in the human body. Once you put them in, it starts a clock, and they will eventually wear out. The older you are, the less likely you are to wear out your valve. But in younger patients, the valves will fail faster. And there's a lot of complex reasons why, but you can think of it as younger patients just put more wear and tear on their valve, and you put a bioprosthetic valve in a 50-year-old, same valve in a 75-year-old, that 50-year-old's going to fail in 5 years, whereas a 75-year-old may live out the rest of his life with his bioprosthetic valve. So guidelines will say for patients, and this is the American AHA, ACC AHA guidelines. It's a little different in Europe, but for anybody under 50, mechanical valve, this 50 to 65 range is kind of patient specific and requires a lot of counseling to come up with the right decision for the patient. And then over 65, most of us would recommend a bioprosthetic valve. And yes, that bioprosthetic valve may fail in the future, but they may be a candidate for a transcatheter valve and valve down the line. So just to go over this decision again between mechanical and bioprosthetic, mechanical valves will last the rest of their life, usually. So much better durability, but you have to reliably take your Coumadin. Whereas bioprosthetic valves, there's no need for lifelong anticoagulation, but you're subjected to structural valve deterioration and the possibility of needing re-intervention on the valve down the line. And in terms of the age cutoff, et cetera, and these are just a couple of charts, one from the New England Journal, one from one of the European journals, showing that there is, in fact, a survival advantage for patients under 55 in the New England Journal study, and the European data would suggest the survival advantage extends to 70 years old for mechanical valves over bioprosthetic valves. So an important part of the decision process. So assuming we're going to offer a bioprosthetic valve to a patient, now comes in the decision, are we going to go surgical or are we going to go with a TAVI? So again, in a high-risk patient or an older patient, TAVI would be very reasonable, but the guidelines say for anybody under 65, SAVR. So why is that? It's mainly because we don't have the same robust long-term data for TAVR as we do for surgical valves. We have decades of surgical valve data. The TAVR was originally approved 2011 for prohibitive risk patients, 2012 for high risk, and not until 2019 for low-risk patients and younger patients. So we just don't have the data to say that you can go either way in somebody under 65. And this is a conversation that you have with the patient when you see them and counsel them about it. In the 65 to 80-year-old range, again, you have to have a conversation with the patient and decide the best strategy. And then over 80, I think many, from a surgical perspective, I would very much be in support of TAVR for the octogenarian population. Okay, was that it? Yeah, I guess. So now just to touch upon mitral valve surgery, it's not really as nuanced as the decision for what to do with the aortic valve, mainly because the gold standard for treating mitral valve disease is surgical mitral repair. But it's important for you guys to know the approach to deciding what to do with the mitral valve depends on the etiology of the disease process. So primary mitral regurgitation versus secondary mitral regurgitation. Primary mitral regurgitation is something intrinsically wrong with the mitral valve. So it's either leaflet disease, elongated cord, ruptured cord, something intrinsic to the mitral apparatus that has gone wrong and is causing severe regurgitation. Whereas secondary mitral regurgitation, the mitral valve apparatus is normal, but the left ventricle, for whatever reason, is very sick, it dilates, the annulus dilates, and you no longer get coaptation between the anterior and posterior mitral leaflets, and that's causing the regurgitation. So the guidelines and the treatment strategy are a little different. Secondary mitral regurgitation patients are often a much sicker cohort and require a little bit more nuance to think about what to do. But the bottom line is mitral repair when you can, replace only if you have to, and the transcatheter edge-to-edge repair, or TEER, as you may have heard, is a good strategy in patients who are too sick to undergo surgery. That's basically the bottom line. And just so you guys see what that looks like, I don't know how much exposure you've had to these treatment strategies, but on the left is an example of this kind of transcatheter edge-to-edge repair. You're just grabbing the leaflets, putting a clip on it, and forcing them to coapt. Great strategy in sick patients who can't undergo surgery, but the results and the freedom from MR are not nearly as good as with a surgical repair. And then just something to be aware of, under investigation are several different types of transcatheter mitral valves, but we're just not there yet, but it's coming. And then, finally, we'll talk about decision between PCI and CABG for revascularization, patients with coronary disease. So the guidelines, again, very strongly recommend that it's a heart team approach and a discussion with the patient and between the interventional cardiologist and the surgeon. There's often it's clear which one to do, but a lot of cases the optimal treatment is unclear and requires a discussion. There's been a lot of back and forth in the literature about what's better, but you have to look at all the patient factors and the coronary anatomy most importantly. So do they have left main disease, three vessel disease, how complex are the lesions, how calcified they are, how many lesions, etc. You look at the patient factors and risk factors, comorbidities, and then certain other procedural things. So just to touch on the complexity of the disease. So there's something called a syntax score. Now in practice, not everybody plugs these numbers in, but it's something that you may hear about, and it's basically a measure of how complex the disease is. Where is it? Is it at a branch point? For obvious reasons, if you have a blockage at a branch point, then to stent it becomes more difficult. The stent is just a linear tube. There are a lot of bifurcating stents now and a lot of very sophisticated percutaneous methods to treat it, but it is more challenging. So a lot of factors to consider here. And in terms of the guidelines, just to look at stable ischemic heart disease. So the reason we treat stable ischemic heart disease is to either improve symptoms or to give a survival advantage. So the patients who benefit the most are those with left main disease or three vessel disease. And this is in terms of revascularization, be it PCI or CABG. And just so everybody knows, stable ischemic heart disease, we're talking about patients who have stable angina or dyspnea on exertion, not folks coming in with MI. So the decision between CABG and PCI can be a little nuanced, and it's really important to collaborate between the surgeon and the interventional cardiologist, have a conversation. I go down to the cath lab, I look at the films with the cardiologist, and it's the era of it's my way or the highway kind of stuff is gone. There's no place for that in modern medicine, so it's got to be a collaboration and a team approach, making the right decision for the patient. And the bottom line is in terms of which way to go, patients with very complex disease including significant left main disease, often do better with CABG. Patients with a high syntax score, meaning complex disease, do better with CABG. And particularly, the advantage for CABG comes in the fact that we put the lima to the LAD. So that graft will hopefully last the rest of the patient's life, whereas a vein graft and a stent are kind of equivocal. They both will fail over time. The benefit of CABG really is that lima to LAD graft and any other additional arterial grafts you're going to do. And let's see. And then there's some debate of diabetic patients doing better with CABG, but that's kind of been debunked in the literature now. What else? Okay, so bottom line, it needs to be a collaborative effort. You need to make the best decision for the individual patient, and that requires a multidisciplinary heart team. Questions?
Yeah. Thank you, Dr. Koeckert. Does anybody have any questions for the panel before we move on to our next lecture?